Welcome to Detangle, where we untangle the complexities of life one conversation at a time. I'm your host, Dr. Kinjal Goel, a psychologist and a writer. Our guest today is one of India's most renowned endocrinologists, Dr. Uday Phadke. Dr. Phadke is the Director of Endocrinology and Diabetes at the Sahyadri Group of Hospitals. He has various publications in peer-reviewed international journals and chapters in textbooks. Dr. Phadke has done his advanced preceptorship in endocrinology from the Johns Hopkins Institute, Baltimore, USA. He is also the recipient of the Srimati Bhandarkar Award for Academic Excellence. He loves the work of P.G. Woodhouse and Pula Deshpande. Along with being a national-level table tennis player, he has also won the state prize in German. A mountaineer at heart, a lover of languages, he also loves traveling. It is indeed an honor to have you with me, Dr. Phadke. Thank you so much for joining me on Detangle.
Thank you very much, Dr. Kinjal. Pleasure being here.
Let's get started, Doc. There are so many questions that I have for you. There are so many things that the audience wants to know because you are dealing with one of the most important diseases of our times, diabetes. So, Doc, what makes a chronic disease like diabetes difficult to manage in some patients?
I think there are several reasons. I think the first emotion which the patient faces when he or she is told that diabetes has now come is, oh my God, there is going to be a disease all my life now. And that's always very tough to handle. There is also this fear. They might have witnessed people with diabetes getting into complications, near ones, dear ones, somewhere a heart attack, a stroke, someone has had a bad foot injury with amputation, and it all comes to your mind in a flash and they say, oh my God, this disease can cause complications like this. So on one side, there is fear. On the other side is this strong resentment that I don't want a disease which is there for life. Okay, I'm stuck now. Also, there is this feeling that I can't live my life happily now. And I think part of all of this is pretty true from a patient's perspective because ultimately diabetes is perceived, and not incorrectly so, as a disease which does bring about its own restrictions on lifestyle. So this whole feeling that I will not be able to enjoy life, live with gay abandon, I won't be able to enjoy food, etc., does play on the patient's mind. So the initial emotion is of stress, severe stress, denial, fear. To begin with, typically, these patients will be very enthusiastic in following whatever you tell them.
Okay.
But the second part of why they don't necessarily behave themselves or manage themselves well is that diabetes is largely asymptomatic. It doesn't really cause problems day to day.
Right.
So it's not that every day you're going to get some heart problem or nerve problem. By and large, a lot of people have no symptoms whatsoever, even if their blood sugars are very high. So after that initial, serious enthusiasm in trying to do something, comes the realization that even if my blood sugars are high, nothing necessarily happens. So I can take it a little cool, which is not correct, but it falsely puts them in a position of, complacency. And then I think a large part, which I detest the most, the first two, are relatively easy to tackle with intelligent patients. You can actually make them, you can talk to them, you can work them out of their fears, you can show them what can happen if they don't do well. But this absolute trash that is dished out daily in a variety of print media, sound media, social media, all kinds of so-called experts talking, WhatsApp groups, that creates the biggest problem. The patient starts believing that what my doctor told me is actually not correct. And there is much more to it, which I don't necessarily need to follow this doctor. All of this leads to this complicated cauldron where patient ultimately gives up and doesn't do well. So this is, I would not say most of the patients do it, but a lot of them do, and they are the ones who land up into problems.
Acha, so in your practice, how often do you see patients trying these counterintuitive methods to get rid of or completely reverse their diabetes?
Oh, I see them pretty often. And, at one point of time, I used to believe that the more intelligent or more educated you are, you might be more amenable to scientific therapy or explanations, sticking to algorithms, listening to your doctors. And I think that is completely wrong.
Really?
I may be judgmental, and I don't want to make this a generalization, but I think many doctors have started feeling that people who come to them, say from relatively rural areas, low socioeconomic status, are the ones who blindly follow what you say. And when that happens, it actually places a lot more responsibility on me, because they said, look, you tell me what to do. I'm not interested in all your theories. You just get me better, get my sugars normal. You say this medicine, fine, I will do it. But those who have access to a lot of information are the ones who will start exploring. I'm not blaming them. I don't think my word is the gospel truth in the entire world. They're open to looking at other things. But everyone knows how the internet can also be manipulated. It will show you what you're searching, and then they lose track. So they do a lot of counterintuitive things in the hope that there is a magic cure where I don't need medicines all my life. I can eat what I want. And I can say that this sugar is actually all right because someone in America said the criteria have changed. They have no documentation of this, no authentication of this. They just believe in it.
Because it's easier to believe rather than to
They want to believe in it. So a lot of people use these counterintuitive measures at least for a period of time. And once they start realizing it's not working, they might perhaps go back to their doctor. Perhaps, unfortunately, by that time, some complication kicks in. And then they feel the need to go back and actually start back again. So this we keep seeing very often.
Really?
Yeah. So these are phases. Initial gusto, followed by complacency, followed by doing all these kinds of counter intuitive measures, and then finally coming back to the science that I believe in. I'm not saying mine is the only science, but some sort of science, structured science.
So what is the craziest thing that you have seen a patient try?
There are several. But the funniest thing I've ever heard is that I had a patient, and mind you, this fellow was a double postgraduate. He held 2 master's degrees.
Okay.
And he had an industry. He ran an industry of his own. So by no means uneducated or unlettered. This guy had bad diabetes. It's not that even some diabetes are relatively easy to manage, but this guy didn't. There was a strong family history. One fine day he came to my clinic. He said, look, I want you to give your patients, all your patients, something which I'm trying. And I said, what is that? So I said, have you found some new method of diet or some exercise or some meditation? I was actually trying to joke with him a little bit. He bought a packet and kept it in front of me. And he said, open it. And there were some dried petal-like leaves. Actually, they were petals.
Okay.
So I said, what do you do with them? So he said, for the last 15 days, I've been told to put these petals in warm water once in the morning, once in the evening. I dip my feet in them for 5 minutes.
I thought he was consuming it.
No, I would have been happier to note that because at least he's doing something. He used to place his feet in that water. And he said, my diabetes is going to go away in the next 20 days. So I said, why don't you come back after 20 days?
Okay.
And it took him about 5 years after that to come back to me with multiple complications, unfortunately, after he had a stroke. But, you can just imagine how shocked I was. And I said, look, man, do you really believe in this? And if you want to try it, why don't you check your sugars? He said, no, but it's going to work. I've been told. This has been tried by thousands of people, etc., etc. Another guy bought a mattress worth 1.5 lakh rupees. And this was about 15 years ago.
Okay.
And he told me, I said, are you crazy? So he said, no, I've got such a fantastic deal. Actually, it cost 2,50,000 or something. Okay. I got it for 115, a limited offer or something. I said, what do you do with this? He said, no, you sleep on this and the diabetes will vanish. So it has got some healing properties in this mattress. I said, fantastic. I'll open a dormitory All of you can come and sleep here on these 150,000 mattresses and get better. So, and this guy again was an engineer by profession, a contractor. So I wonder, but this kind of thing just takes over and they just lose. You can't really
make
them see sense at that period of time at least.
So, Doc, there are a lot of causes for blood sugar spikes. You'll know all of them. We know most of them. Stress has been in and out of the picture in the last few years. Some people believe that stress can cause a spike in blood sugar levels. Some people are now starting to believe that sugar doesn't cause diabetes, only stress does. So where are you on that?
So the second part of it, that sugar doesn't cause diabetes, only stress does. So it's much deeper than that. Now, diabetes occurs because of a multitude of things, but at the heart of it, so I would say there are genetic factors for the typical type of diabetes that we see in India. That is the adult onset kind of type 2 diabetes, as we call them, not the juvenile type 1 where insulin is necessary to preserve life. But this type 2 diabetes is a whole lot of things, but there are certain genetic factors which you have acquired through generations of your ancestors, and these genes basically control how your body utilizes energy, how it stores energy, how it produces insulin, which is required for blood sugar control, and how insulin is effective. So the insulin action also, the insulin production also, a lot of things are controlled by genes. And then there is the environmental factor, where how you weigh, how much you weigh, what is your waist circumference, how much fat is there in the body versus how much muscle, what is the level of your activity, what is your age, all these things matter, and of course what you eat. So if you consider, there are so many factors that are necessary to first cause diabetes. So you will know that many people who are seriously obese, but who have absolutely no diabetes in their family may never become diabetic. So it's counterintuitive sometimes for us to see, oh my gosh, you are so overweight. His sugars are bang normal because those genes have not come in.
So blessed.
So they're blessed. That part they are blessed. They may have something else, but diabetes they may not have. Now, apart from all these two, only having stress is difficult to cause diabetes unless it's a short-term severe stress. So like, for example, somebody gets into a serious accident, gets multiple injuries, those injuries become infected, you're in the ICU. And there, if you have had little borderline diabetes, because of this immense stress, the sugars can spike. There's no doubt. And they can go up to 300 also.
Okay.
Even when you have not had diabetes before.
Right.
But what we see typically is not this. What we see most often is that a patient is diabetic, broadly well controlled, I would say, moderately controlled, and then there is some stress which is occurring. Now, this stress is something which is very difficult to quantify. You cannot measure that I have 8 on 10 stress.
Right.
Stress can be different things. For me, sometimes stress is seeing too many patients in the clinic. For somebody else, that's great fun. Oh, I have 50 patients waiting in my clinic. I get very upset when there are too many people waiting. Someone will say, look, my OPD is full. So it's all very differential. But the typical family stressors, economic stressors, having some other illness which is causing a lot of trouble can be a serious stress. Having a disabled child can be a very severe ongoing stress. And what stress does is it elevates certain hormones. In order to counter that stress, the body makes certain hormones like cortisol, like adrenaline. We say there's an adrenaline rush. So that's what the body is doing to help you out of the stress. But all these hormones are anti-insulin. So they act against insulin and they will always spike sugars. Now, on the other hand, there is this so-called chronic stress. That means I go to office every day. I have to travel by the local train for 1 hour and then come back and do these things. Now, I don't know how much of that affects sugars. Perhaps if they just give it up and retire to the mountains and sit by a lake and maybe eat some very
raw, green, organic diet,
rich food, green food, maybe I think they will. But if they are genetically diabetic, if they've had diabetes, it will reduce the sugars but not completely take it away. So the stress is very important. I think I don't like to blame stress too much in my conversations with patients, is because ultimately what happens is, if you keep saying, oh, yours is stress-induced diabetes, what people think is that, oh, it's not my responsibility anymore.
It's the
stress. I can't do anything, so I will not do anything. Once my stress goes away, the diabetes will go down. No. Whether you eat 10 jalebis and your sugars goes up, or you have stress and your sugars go up, your kidneys are going to be fired in the same way.
Right.
So you will still need to take precautions. Now, if you're so stressed, you need to see a good psychologist, psychiatrist. You need to do other things. You need to find out how to counter that stress. But you can't say, oh, I don't have diabetes, I just have stress-induced sugar. It's the same thing. It's diabetes. High sugars is diabetes.
Right.
Whatever you call it by. So it's all semantics. That's why I don't like people coming and telling me, no, mine is stress-induced diabetes. I tell them it could have spiked a bit, but it's causing the same problem inside.
So it's important basically to understand what is happening in the body. Like in psychology, we say, eustress is stress which is pushing you towards a better goal, and distress is what is making you upset. Exactly. But eventually it is harming your body in the absolute same way. So you can have good stress, bad stress, but it is stress and it is hurting you.
You're very right. In fact, some people, these are few and far between. I would not say they are the majority. Sometimes they say, not necessarily at the first visit, but after a couple of visits, 3 visits, they say, you know what, doc? Sometimes I feel it was good to have got diabetes. Oh, I said, wow, what are you saying? So they said, no, look, see how much my lifestyle has changed. Okay, so I have become more disciplined. It's not that I've completely given up everything, but I've started to try and eat healthily. I've cut down some portions. I feel better. So in a way, you only said this time that your waist has gone down, my weight has gone down, my blood pressure is better, my cholesterol is better. So I'm fine. I mean, I put in a little discipline in my life, which I wouldn't have, just except for this illness. So I'm quite happy to live this way. But keep me this way. I don't want to become worse. So as you said, sometimes the stress also pushes you to improve.
Very interesting perspective. Now, this is not something which you usually hear from someone, yes, but it can definitely improve your lifestyle, because
very intelligent guys. And I'll tell you an example, which I have always been amazed at this fellow. So I once saw a person. They were a kind of rural farmer folk, but they had moved to the city.
Okay.
And they were into jobs in the city now. They were not tending to farms. They had a 14, 15-year-old child who was becoming obese. And because of the obesity, and naturally that was because he was here and eating and all that kind of thing. And because of that, his sugars had started to go up. He was not diabetic.
Okay.
But his sugars were up. His cholesterol was not where a 14-year child should be. So they came to me and I said, look, you're giving him too much food. So they looked at me and they said, we are giving him rich food because now we can afford it a little bit. We have moved to the city. They said, we did not know that giving him good food will cause obesity. I said, you're giving him more than he requires and he needs better lifestyle. He's already on the verge of diabetes. So we had a talk. They said, okay, we understand. And then they went away. And I had a big plump fellow. And after 2 or 3 years, this family came back to me. After 2 or 3 years.
Okay.
Now, I saw their paper and recognized them for their name. I could not recognize that boy as such, okay? I don't also necessarily, but I could not. This guy was absolutely as a strapping, very healthy looking fellow. So I said, is this the same guy you had bought? They said, yes. So I said, what have you done? So they said, after you talked to us, we decided this is not the place for him. So we sent him to my brother's farm somewhere in Solapur district and told my brother, he's your laborer in the farm. So he's been working actually in the fields for the last 2 years, eating whatever they give him, drinking that cows and buffaloes milk straight from the stable. And here he is. Extreme lifestyle change. Right. Very few people do it.
I don't think possible. A lot of people can do it.
I don't think so. But I am saying some people get very motivated. And some just get demotivated.
Yeah. Let me ask you a question which I'm sure is going to be extremely interesting to everybody who's listening, because this is the elephant in the room. Diets. Now, diets are omnipresent. Everybody is on some kind of diet. There are good diets, there are complicated diets, silly diets, some are outright bizarre diets. I'm sure you've heard of most of them. Is there any diet which actually works?
Okay, so that's a lecture in itself. Okay,
sure.
But I will try and simplify it. So, as you said, there are many kinds of diets. Now, broadly speaking, certain diets in which you selectively take away a few things and just add a few things, okay? Something very specialized and exotic. We call fad diets.
Okay.
So, you say only fruits from today. Now, nobody eats only fruits in their normal life. So you've taken away a whole lot of things and only put in a certain substance, fruit. We call that fad diets. Now, to simplify it, all diets work.
Okay.
Anything will work at a certain period of time. For example, the whole point is change. You change something. For example, you'll be very surprised to know that today, if you're in the habit of having breakfast, and from tomorrow I said, no breakfast from tomorrow, you will improve. Okay. For someone who doesn't eat breakfast, and I say, no, you must add a little breakfast. It's important. He or she will also improve. So the only thing that we are doing is changing something.
Okay.
But that doesn't necessarily normalize you. It will change something. This is particularly when you're dealing with obesity and so on. Most of the fad diets will work for a short period of time because it all depends on... So they work. There is some science behind it also. So for example, keto diets, where you totally or practically take away carbohydrates. Your sugars drop through the roof, your cholesterol drops through the roof, and your weight drops. The problem is, how long can you sustain? Most people, or for example, the plant-based diets, you just drink smoothies. Good, I have nothing against them. Your sugars will drop because you're drinking a natural plant juice without any sugar. Your diet is also changed. You will improve. How long can you do that? And people come back with a vengeance saying that I hate green things.
Right.
I'll not even wear a green shirt now. So stop me. And I don't care. You put me back on drugs or you do what you like. Don't show me that thing again.
Okay.
It's that bad because you get nauseated. And that's because the human brain is basically evolved for pleasure. It's not like the animal brain where... So we always say that there are 2 or 3 kinds of eating patterns. One is what we call the executive eating pattern. That means you know you need to eat when you're in company, you're in a meeting, everyone is eating, you at least need to pick your food. The other is called homeostatic eating, which means I am hungry, my body needs energy, I must eat, I have not eaten since morning. You need that. It's not a choice. It's something of a necessity.
Right.
This is fine. The third is the most dangerous, and that is called the reward eating.
Okay.
Where only the human brain does it. Okay. So, evolved human brain. So, even a child, an infant, once its stomach is full, no matter what you give it, it will just throw it away.
Right.
A human, give him a full meal in a big restaurant and you bring him and say, now have a couple of scoops of ice cream. Bingo. No problems. That is because the brain says, oh, this looks nice.
Yeah,
so
it'll feel nice eventually.
The reward mechanism, if it's taken away, brain feels very dejected. And people who are doing these kinds of diets often report a lot of irritability, crankiness, fuzzy thinking, because they are not getting enough carbs. So I'm not saying you should get a lot of carbs, but the brain is like that. That's number one. So ultimately what works? I think ultimately, if you're intelligent enough and disciplined enough, what works is a common sense diet.
Oh, I love that term. I've heard you say this before and it really sticks.
Absolutely. So we also don't like the word diet, because when you say diet, it necessarily means, oh, take this off, don't eat that, don't eat that. So the ADA has come out, the American Diabetes Association, and many organizations have come out with a very clever word. It's called medical nutrition treatment.
Oh,
so
nice.
they say this is treatment. This is not, we are not taking out anything.
There's
we are
no
treating.
restriction.
There's no restriction. We'll tell you what to eat. And then you sit and say, okay, look, because your sugar is like this, because we'll need to balance this a little, so much fiber you add. And the most important thing that we take care in planning this is we don't go away from the ethnicity, the local foods. That's very important. For someone who comes from Satara, if I tell him, okay, in the morning you're eating a chapati with some vegetable, you start taking some quinoa. He says, what are you talking about, man? So don't do that also. It's not necessary. Use local foods. Correctly adjust the quantities and the proportions and stick to it so that you don't feel robbed. Once in a while, a cheat day is fine as long as you don't keep doing it. The idea is to sustain it for longer periods of time rather than do bursts of keto or then some fruit diet or South Beach diet or GM diet and then letting it all go to waste after a couple of weeks.
So what I see here is that all of us are able to lose weight or control our blood sugar levels if we stick to something. So it is persistence which matters and not these short bursts which can eventually be harmful. Understood. Doc, tell me, I have known you for a very long time as a professional, and I know that you can notice when a person is stressed beyond the usual stressors or has something which is stopping the medicines from working right. There are times when you don't know what is wrong with the patient, but you have a sense that this patient needs more than just diabetes medication. What do you do when a patient like that comes to you? How often do you need to refer them out to a mental health specialist?
Lots of times. And I think every physician worth his salt, when he sits in the OPD, his outpatient's clinic, will see these patients, where a few things can be explained by his reports and tests, etc. A lot of things have to be ascertained from body language, the way he's speaking, the way he's compliant with medicines, tests, how he's interacting. And not surprisingly, we see so many depressed patients, anxious patients in the clinic. It's not surprising because depression is the number one disease on the WHO list today. And diabetes itself makes people feel depressed. So there is this feeling of dejection, of helplessness when they're trying everything. So they're trying diet, they're trying exercise, they're taking medicines, still the diabetes is not doing well sometimes, they're still getting complications. So this dejection comes in. We see a lot of this when they start developing some sexual dysfunction. So there is intermarital discordance. So a lot of things start happening there. And unless we address this, nothing is going to work. Because if diabetes is accompanied by depression, they don't do well. Also, if you treat the depression in the diabetes, they do very well. That's also been shown. So intervention also actually works. So I think it's very important for doctors to recognize depression. And I wouldn't say everyone needs to be referred to a psychiatrist. You can start medicines if you feel it's correct, but at least recognize that there is a mental side to any chronic disease, particularly. There are so many things. He may be spending quite a bit on his medicine. That itself may be a stressor. True. You may not realize you're writing the most modern medicines. Have you sat down and calculated how much from his packet is he actually spending his own self? It may not be tenable. So we have to be very alert. So typically when we see patients slipping off from their targets, not doing well, don't seem interested, wife says no matter how much I tell him, he will not go for a walk. Why? There has to be a reason, right? I mean, you can't just say he's lazy. So then you ask him, he says, I don't feel like, I've lost that interest. And that loss of interest in things which kind of held you before is depression, right? I mean, what else is it? So we treat some, we talk to some, but the rest we do send to psychiatrists, psychologists, whatever their need be. And I think they do very well with help. So initially they may also deny taking that help because there's a stigma. But once they get better, they'll come and thank me profusely. They said, good, you insisted. I'm so much better. I think it's very important to recognize the mental part of chronic health.
I think the key word here is recognize and validate. When you recognize that your patient needs help and you validate it, it's half the battle won.
Yes, absolutely. And you need to talk to the patient. People will immediately outright reject suggestion of seeing a mental health specialist because of variety of things. But you need to tell them, no, you will do well. Just believe in me sometimes. Fortunately, we practice in India. So we can use this statement, believe in me, believe in what I'm saying. You can't use this statement in the United States or Britain. There's no such thing in believe in me. You just place it in front of them and let them take a decision. Here I can say, look, I'm telling you, just go, okay? Most of the times people will follow. Still they do.
Yes, because they know that you have their best intent at heart and you will do something to help them feel better. Another question, Doc. So what's the one thing about the mind and diabetes that you learned rather late and you were surprised by?
That's, well, I would say I started learning how you need to formulate your responses, means as a doctor, based on your interaction with the patient. So I would say the diabetes and his mind, okay?
Okay.
In the sense, let me give you an example. I don't know if it's the most apt example to the question you're asking, but still let me try to answer that. So sometimes I get people, okay, more than the disease or more than what you're giving them as a medicine, they would like to know what's happening, okay? So then if I give them a lot of things, see, this is how your pancreas senses your sugars and this is how the insulin is released and then it, etc., and how the sugar gets metabolized, they feel very thrilled. The same thing if I talk to a rural fellow. I go to Jaigaon once a month. I've been doing that for the past 25 years plus.
Oh, lovely.
Yeah. And I see a completely different community there. A class of patients, not a community, but a class of patients. There they say, look, we are not interested in all this. I am getting tingling in my left hand. Just get me rid of that. Period. You do what you want. In a way, that's simpler. I just prescribe something and I give him some words of comfort. Ho jayega. And most often, as you know, many simple things get better on their own. The first one is a little tougher nut to crack because he wants science and all that. But also sometimes it's good because then you can say, look, now from science, I can't tell you what this is. So you need more investigation or I don't know what to do. I can say that. So I have learned basically to talk to people based on what their mind is saying. I've also learned to pick up what is their fear, and that requires a little bit of experience. So somebody may come for innocuous, thyroid, marginally raised, some abnormal, but their fear is not that test. Their fear is, will I get thyroid cancer? Now, it's nowhere on your horizon also. Why are they thinking about thyroid cancer? That's his or her fear. There is no rationality in that. But once you start picking up such nuances, you address that fear first, the patient is very amenable to listening to what you have to say. Or if you say, look, don't worry, your kidney is fine. To a diabetic patient, your heart is fine. He said, oh gosh, thank God. I am always fearful that my kidney will get fired. It's very common, huh? There is nothing suggestive of any kidney disease. It's just a fear. And you say right at the outset, now how do I catch it is, I can't explain it. They look in a certain manner, they're a little furtive and they don't seem comfortable. And you say,
drop
look,
a word here.
So kidney must have, quite no problem. Don't worry about your kidney. Then they are easily more accessible. So those kinds of
So things you don't learn in college.
You don't learn in college, you're never taught in college. I wish they were. But I think it's difficult to teach also what you are actually getting from the patients.
True. I think it's a lot of experience. It's a lot of experiential learning. And I'm sure a lot of people will listen to this and say, okay, if they are clear enough about their fears to their doctor, the doctor can actually help them better and stop the guessing game.
Absolutely. Absolutely.
Let me ask you a very personal question next. We all know that we have a first aid kit in the house. Everybody wants to keep some band-aids, they want to keep some Savlon, maybe a painkiller, for those days when you have minor cuts and bruises and you just want to make yourself feel better. What if we have a mental first aid kit in the house? A little box which you can open if you've had a traumatic day, if you've had a fight with someone, or you're just feeling low. And when you open the box, it makes you smile. It just takes away the day's woes, just a little bit. If you were to have a box like that, what would you put in it?
Oh. So I would have two things in my box. Mm-hmm. And I don't have a physical box like that, but this is what I do if I really feel bad. One, of course, is physical exercise. I like to go out and walk, but that's one. But if that is not possible, I would like to open up my big albums of photos, digital now, because I do a lot of nature photography.
Oh.
And I have hundreds of them. And I can relive those moments which are nowhere so marvelous. And they were alone because you trek alone. Although you may be in a group, you are basically alone there.
Right.
So I have some brilliant sunsets. I have some brilliant seashores. I have brilliant mountains, snow caps. I'm fine looking at them. I can go there again. And I have two kinds of books in that so-called box that you have. One is PG, and there are a couple of books which I can read, hundreds of times. Maybe I've read them hundreds of times. And Pula Deshpande in Marathi. These two are masters of language and masters of humor. So I practically know Pula by heart. Oh yeah. So I don't even need to open a book. I can say, okay, I'll think of this chapter and I'll laugh to myself.
How nice. So you're pulling it out of memory.
Absolutely, I do. So these are amazing people, and it doesn't fail in getting you back.
I would love to see this box someday. It sounds like an interesting one.
I wish there were a physical box like that. But yeah, you're right. The question is very interesting, because what does one do at the end of the day if you feel bad, what do you do?
And it's nice to have something tangible, something accessible, something small, but something you can use. Well, as we come to an end of the podcast, I always leave the floor open for my guest to ask me a question as a psychologist. Is there anything that you would like to ask me?
Yeah, certainly. I have always been intrigued. Okay, so in mental health, you may have very, disorders like psychosis, schizophrenia, which have to be managed by medications, and there's nothing else, or serious depressions. Then there is this whole lot of things which is anxiety and what one would call functional disease, or hypochondriacs, or these somatic symptoms.
Right.
We as doctors of, let's say, medicine, let me say, we find very difficult to cope with these symptoms. You get irritated and you don't know what to do with them because you can't find anything, and they are there. So I'm sure you have written that book, and one cannot, just tell them that, come on here, it's all in your mind and just forget about it. No, you can't do that. They're there. How do you actually talk to these patients has been always a mystery to me, and what happens to them really, because we can't cope with them. I'm very honest.
I think the most beautiful part of this question is the fact that you are frustrated by it, which means you really want to make your patient feel better.
Yes.
That is a very good starting point to have. Yes. That you have not dismissed your patient, but you're frustrated by your inability to help in the most appropriate manner.
Absolutely.
So let me answer this by first telling you what you should not say to your patient. The most counterproductive statement that a doctor makes to a patient is, it's nothing, it's just stress. The minute this statement comes out, the patient feels that this is not a valid cause, it is not a valid symptom, they are faking it, they feel responsible for their symptoms, and everything that psychotherapy would have probably been able to accomplish, it just breaks down. Best thing to say is, look, right now, I don't see a structural or organic cause to your symptoms. Let's get a psychologist or a psychiatrist involved and come back to me after 4 weeks and we will reevaluate. When you leave the door open, a patient feels that, okay, I'm not being banished into the dungeons of psychology and I will come back and then the doctor will see me again. Usually what happens is the patient will not come back. They will start feeling better with therapy.
So my question to you was, what do you talk to them?
That will be a whole lecture by itself.
No, I understand. So I completely understand you cannot explain to me in one sentence, but I'm sure there's a structured kind of...
There is, right? So there are structures, there are different kinds of therapies. REBT, CBT are the most commonly used ones. There are psychometric tests involved. You can objectively help a patient understand what their issue is. Sometimes the stressor may not be current. It may be rooted in the past, and so it's not as easy for the patient to understand that this is causing the problem. There are some bad networks that we have in our brain which need to be unraveled or detangled, as we say. So we help the patient gain insight.
But you feel they are helped, right?
Absolutely. And we never give advice. We always help the patient gain insight.
Absolutely. So that's great, because if you're helping them, then that's fantastic.
Absolutely.
That's nice.
Well, this has been a very interesting conversation, Dr. Phadke. It has been very, very intriguing for me to see how diabetes has now come to the forefront in the minds of people. I think this is one of those diseases where we have as much misinformation as information. We are kind of propagating it through social media. We are sharing information without checking it. But from what you say, it's all part of common sense. If you can stick to the basics, you're going to do well. If you can help others around you stick to the basics, they are going to do well. So instead of falling prey to all this propaganda, I think we just need to use our common sense.
Absolutely, you nailed it.
Thank you so much, Doc. It was wonderful having you.
Pleasure.